Hi, welcome to my channel Dentistry with Kashaf. Let's talk about very important topic. Did you know what is amelogenesis? Amelogenesis is the formation and mineralization of the dental enamel by a specialized cell called as ameloblast. What are the stages of amelogenesis? And we know that the first stage is a pre-secretory stage. Ameloblasts differentiate from inner enamel epithelium cells and prepare to produce enamel. You can appreciate here the ameloblasts are elongated and they are just ready to secrete enamel proteins. Okay, secretory stage, you can say that in secretory stage, the ameloblast just producing that of enamel proteins, like mainly amelogenin. And initial enamel is just from here, which is non-mineralized. In maturation stage, you can appreciate the early maturation stage and late maturation phase. In early maturation, you can see the ruffle border, and in the late maturation, you can see the smooth border. In the ruffle border is basically exchanging calcium and potassium with your the matrix, the proteins you are producing, like in the previous slide. And in this slide, you can appreciate that it is re-engulfing, or you can say reabsorbing the mineral and protein, like water and protein are reabsorbed, not minerals, and the minerals are deposited here. You can appreciate that crystals are elongated, and these are basically enamel crystals. These are ameloblasts. These are enamel crystals, and these are well mineralized, like well matured. In fourth stage is a protective stage. Here is the ameloblast from the protective covering over the enamel neural form. Like you can appreciate this protective covering, and it is forming till the tooth is erupted. There is also an alternative stage between the secretory and maturation phase, that is a transition phase in which the cellular changes occur and no change in the morphology occurs. But wait, did you know what will happen if this mechanism is disturbed? Yes, there is a condition called as amelogenesis imperfecta. This is how it looks like. What are the clinical features of this condition? There will be yellow-brown discoloration of the tooth and small misshapen teeth will be present, like irregular type of teeth will be present, not normal. Generalized enamel defects are present, like all the teeth are involved. Gingival inflammation due to surface roughness, like tooth is a condition due to which the gingiva is inflamed, reddened or swelling. And there will be a delayed eruption of some of the permanent tooth due to deciduous dentition was affected. And the funny thing is that it can affect both deciduous as well as permanent tooth. But wait, does it have any other types? Like we discussed the clinical features, but we know that yes, it does have 5 types. Type 1 is hypoplastic amelogenesis imperfecta. Enamel quantity is defect. Do you get this thing? Enamel quality is good, but the quantity is less. That's why enamel is thin, and it is thin or pitted. Teeth appear small with grooved orbits, may be sensitive to anything. How and what is the reason behind type 1 hypoplastic? There is a defective matrix formation. Like in secretory stage, we said that ameloblasts produce some proteins like amelogenin, etc., and the matrix proteins are produced, so those are defective. That's why those are less defective. Those are less produced, so they are defective. So you can say reduce enamel matrix quantity. That's why enamel is thin. What are the clinical features? Generalized pitted condition. Pitting is present, and localized pitting can also be isolated there. And smooth or rough surface. It could be smooth surface or yellow teeth, or it could be rough surface with some pits. We talk about the radiographic features, so there is no any specific thing, but you can see that localized pit, like visible as tiny radiolucent defects in this condition. Then let's move toward its histopath features. There are nothing important. If you see the diagram, there is a disorganized prism pattern, and there are localized pitted features. Like you can correspond to the focal enamel absence. Like there is a white spaces you can appreciate here. So these are basically pits. Fewer hypoplastic ameloblasts are present. Like ameloblasts are less in number, they produce less protein. So you can say enamel is basically the quantity is reduced, but the quality is okay. So here it is mentioned already, reduce enamel volume. Okay, let's move towards type 2. You can say hypomaturation amelogenesis imperfecta is a type. Enamel thickness is normal but soft. Okay, thickness is normal. Like here is enamel quality is defected. Quantity is okay. Like 100 cells are produced by 100, but those are low in quality. Like their function and their role and their form is not that much good. The quality is affected. Enamel thickness is normal but soft, less mineralized and chalky in appearance. Teeth are often opaque and discolored. If it is chalky and it is brittle, it means there is a problem in maturation stage. Like we say that calcium and phosphorus are exchanged and the enamel is mineralized there in that stage. So if you see, if this stage is defective, it means that the quantity was produced but the quality will be reduced. Unremoved protein matrix, we said that proteins and water are absorbed back, so they are remain, so that's why it's not properly you can say the maturation stage is not properly performed here. Talking about his histopathological features, so you can say enamel thickness is usually normal. Like we can say that the quantity is normal, but incomplete removal of enamel proteins, we say that the maturation is defective. Enamel crystal fail to mature completely. Enamel appear less dense and more porous, like a bit severe than the first one. Poorly defined enamel rod prism pattern is present. There will be some retained organic matrix. Like in maturation stage, it is important, like all the organic content is replaced by inorganic, but some of the organic matrix is sustained here. Okay, whereas hypomineralized prisms are present in poorly defined prism structure, normal enamel thickness but defective mineralization. Then talking about its clinical feature, so there is a very well known thing, snow capped appearance in type 2. Okay, and there will be soft generalized motile cheese like appearance, like generalized type of condition. If we talk about the radiographic features, some areas will be radiolucent, some areas will be radiopaque, so this on and off will go there. This is a normal like thickness but soft and porous enamel. As we said, the quantity is normal but the quality is defective. Then there's a type 3 called as hypocalcified amelogenesis imperfecta. Enamel quality defect. Still here is the enamel quality defective. Enamel is normal thickness but poorly calcified and prone to rapid wear and breakdown. How it looks like this. Okay, then we talk about why this thing occur in early maturation phase where there is a damaged matrix forming but with mineral crystals. Okay, early maturation stage, we already discussed about the maturation stages. Okay, there will be like ameloblast, we say that it will be smoothened later and all the proteins and organic matrix will reabsorb, but there is a defect in calcium and phosphorus deposition, like early type of thing, so that is defective. Like we know that maturation stage have early and late maturation. Early has calcium and phosphorus exchange and late has basically all the organic matrix is reabsorbed and only the hard enamel is left, like crystals are grown and stuff like that. Then we talk about its histopathological features. So this is obvious. Enamel thickness is usually normal in both type 2 and type 3. Severe deficiency in mineralization, like early maturation is defective. High organic content remain within the enamel. We know that. And enamel is soft and friable, like more worse than type 2. It could be easily wear off. And poorly formed enamel crystal will reduce calcification. Obviously, if the early maturation is defective, so obviously the later one will also be defective. You can see loss of prism boundaries, mark porosity, and extreme thin and fragmented enamel. Okay, scatter non-clarified matrix elements, and also type 2, type 3 both have good quantity, but the quality is defective. There is a difference in maturation. Some have late maturation defect and the other have early maturation defect. Talking about the clinical features of type 3, so we know that this is a generalized condition in which a very rough, soft, moth-eaten enamel and rapid enamel wear fractures occur. Like you can say these are basically flat in interproximal spaces, like completely wear off. Severe yellow-brown staining. In severe case, radiographically, you will appreciate that enamel layer has extremely low radiopacity, equal or less. It might be equal to less than 19. Like this is very severe condition. Generalized moth-eaten appearances and total loss of the normal contrast between enamel and dentine. Like it will look. There will be no differentiation between enamel and dentine. Like we know that enamel is more mineral bearing structure, so it will be more radiopaque, and normally it should be more radiopaque than dentine, but in this case you cannot differentiate dentine or enamel because both have low mineral content and might be similar. Then the fourth type is hypomaturation hypoplastic with taurodontism. Enamel quantity and quality defect with taurodontic teeth. Taurodontic teeth is basically one of the dental anomaly which is actually associated with amelogenesis imperfecta. Enamel is thin, pitted, and poorly quality. Molar short taurodontism. In this, you will always go for molars. Molar with short taurodontism. What is taurodontism? Then basically an enlarged pulp chamber, apically displaced furcation. Like I will elaborate it later. What is this condition like? Combined defective ameloblast. Ameloblast is defective as well as your you know that bud stage bell or cap stage. During that histodifferentiation stage, you might know your oral pathology. And there is some structure called as dental papilla, some cell like outer enamel epithelium, inner enamel reticulate, intermediate cells, and then dental papilla, which basically give rise to your dentine and pulp and cementum, PDL fibers, stuff like that. So that thing is defective as well as ameloblast is defective. So that's why your pulp chamber go enlarge and then go more and more apically in that failed Hartwig epithelial root sheath or diaphragm. Like they cannot divide at right position at the furcation level, but that will basically go down. Like how actually teeth look. This is normal, this is a bit other, and we know there are 3 types of taurodontism. So this is meso, and this one is third one. I don't remember the names exactly, but it has 3 types, and this is the more severe one. Taurodontism is a developmental anomaly in which the tooth has an enlarged pulp chamber. You can appreciate what is this and what is this. Clear-cut difference. Apical displacement of the pulpal floor, like furcation, is going very down, and then short roots and elongated tooth body. Of course, you can barely appreciate the roots, and look at the pulp chamber, it's so big. Okay, the tooth resembles that of bull teeth, and these are called as taurus in some language, called as bull. Taurodontism. Don't means teeth and toro means bull teeth. Hence the name taurodontism. And there is some says that there is a type 5. Mostly there are 4 types we study in book, but type 5 is basically, I just learned somewhere, so I add it here. Hypomaturation, hypoplastic amelogenesis imperfecta without orthodontism, like same condition but there will be no orthodontism, like the same appearance is here in type 4, but it is not associated with orthodontism. It was, and the other was associated with orthodontic teeth. But why it is caused, like what is the reason behind that all that normal secretory maturation and productive stages are affected? Why? Yes, this is wholly and solely genetic. Normally we know that ameloblast will secrete the enamel proteins like MLX, enam protein, and this mmp 20, which are some are responsible for its normal anatomy structure, and these are responsible for its function. But if these ameloblasts are mutated, now this ameloblast is mutated, then obviously these genes are defective, and that will give rise to defective tooth. Then you can appreciate that there is also genetic inheritance patterns, like there is autosomal dominant characters, autosomal recessive, and X-linked. You must know that the etiology of amelogenesis imperfecta is non-environmental. It is 100% genetic. Either it's a defect in ameloblast, like the mutation there, or it might be some genetic inheritance pattern. Okay, don't worry, you can treat it. Good news is that, like general treatment principles, like overall management, like we know we have different types, but what is the overall management? But when the patient is just a kid, pediatric dentistry, you have to take care of his deciduous teeth. Like that's why the early intervention and dental visits are very important. Like obviously these teeth are more sensitive and prone to caries, so you have to give these children some oral hygiene instruction, and to prevent, like you cannot prevent this condition, but you can prevent the worsened symptoms and outcomes of this thing. Like you can prolong the life of those tooth or normal eruption, you can just intervene it, but you cannot stop that condition because you cannot treat that genetic thing. Then you can say we mostly discuss, we are giving crowns, like stainless steel crowns in children. We are mostly doing that for space maintenance and tooth maintenance and caries protection, like absolute caries protection, so things like that. When the patient become adolescent, like then you have to go for definite treatment. Until the patient is a child, you cannot do anything but to protect it. But when he is adolescent in adult dentistry, permanent dentition, then definitive restoration, like you can go for veneers and full crowns, like permanent treatment. Like this will be the lifetime treatment for that patient. And we know that irregular shape, and some are up and some are down, and some are going inward, labio version, facial type, some are buccolingual version. Tooth are just messed up. You have to go for orthodontic and oral surgeries. You might need an frenectomy and things like that, and other gingivectomy. Also full mouth rehab, you can go for like CDs, you can go for fixed CDs, removable CDs, and if it is a local condition, you can go for any crowning, things like that. Okay, hypoplastic condition which enamel deficiency treatment, we said that the quality is okay, but the quantity was less, like it was 50 by 100. So you cannot do anything but microabrasion and composite bonding. Like the enamel busting, you have to just only thicken the enamel layer. Like you can give the porcelain veneers and full crown just to protect it. The main problem there is the enamel is thin and the dentine will expose, and sensitivity is the main issue with type 1 patients, so you have to protect it, like giving the crowns and veneers. And moving towards the type 2 patient, like hypomaturation. So what are these patients prone to? Of course fracture, because we said that the quantity is okay but the quality is defective. So you can reinforce the restoration, like composite of crown, the same we discussed. In indirect and direct veneers, like we can say inlay and onlays you can give. And we know that onlays, and if you see this diagram, this is basically the onlay condition in which the cusp are also covered. So this is basically strength is good and more aesthetic and more compatible as compared to your intraoral restoration, like that of direct bonding. Restoration designed for lower like enamel hybrid or layer type, you can do somewhere you are giving full and somewhere we are giving partially. Like type 3 patient, like hypocalcified amelogenesis imperfecta, severe enamel loss and disorganization is there, then you cannot do anything, but you obviously you have to go for full coverage crowns, like full your just zirconia crowns, and you can appreciate like they are just giving full crown, like completely destroyed tooth are being displaced, or you may go for full mouth rehab. Okay, thank you very much for listening to me. Don't forget to subscribe my channel, and please let me know in the comments what topic I should be covering next time. Bye, see you next time.